Welcome, everyone. We'll get started. Great to see everyone. And thank you for joining the role of the hospital pharmacist in antimicrobial stewardship and sepsis management. My name is Kritika Metawala Hornback, and I will be your moderator today. I am a clinical pharmacy specialist in infectious diseases and antimicrobial stewardship and the program director of the ID pharmacy residency here at MUSC Health in Charleston, South Carolina in the US. My areas of interest include stewardship expansion, gram-negative mechanisms of resistance, diversity and inclusivity initiatives, and training education. And I'm thrilled to be part of this global talk. Some announcements. So this webinar will be recorded and can be live streamed via YouTube. After that, the recording will be available on our website and the link is available for you. Any questions during the webinar can be entered in the question box provided, and I will moderate that session once the time arrives. And then you're welcome to provide feedback. We would appreciate that at the email address provided, and we really encourage you to become a member of FIP. You can register at that link. This is just a brief overview of today's programming. We'll do the opening remarks, and then each of our three speakers will provide their presentation. After that, we'll have a panel discussion where I will field some of these questions in the Q&A box, and then we will wrap up and conclude this webinar. These are the learning objectives for today. I will pause for a brief moment so you can read them. Great. And with that, I will introduce our first speaker. Our first speaker is Dr. Esteban Zavaleta. He's the director of pharmacy at the Hospital Clínica Bíblica in Costa Rica. He's a pharmacist who graduated from University of Costa Rica School of Pharmacy and has a 15-year experience in hospital and clinical pharmacy. He's also involved in clinical research activities and has published several papers about medication use and practices. Dr. Zavaleta, the floor is yours.
Hello. Yeah, thank you. Hello, everyone. It's an honor for me to have been invited as presenter in today's FIP's webinar. I believe this subject is highly relevant due to the key role that we pharmacists might play in the management of infectious diseases, such as sepsis, and in supporting other healthcare professionals in the antimicrobial therapy decisions. Next. Today, we will be covering the following topics related to the pharmacist's role in sepsis management. We will talk about the surviving sepsis campaign definitions. We will talk about sepsis screening tools, the treatment goals, and the pharmacist's role in sepsis management and what's the evidence actually and currently published. Also, we're going to end with some key takeaways that I believe it's important for us to understand. Next. Next and next. You know, it's important to know where all these definitions come from. And I think the International Surviving Sepsis Campaign is a joint initiative committed to reduce both mortality and morbidity in sepsis and septic shock. One of the latest guidelines were presented at the 2016 Critical Care Congress in Orlando. And this guideline provides several evidence-based recommendations for the management of sepsis patients and is directed to all healthcare professionals, especially critical care physicians, but also pharmacists. During last month, on October 2021, an update was published, and you can access it for free if you wish to have further reading on this topic. We have seen this update is more complete about the care of sepsis patients after they are discharged from the ICU, but also represent greater geographic and gender diversity than previous versions. Next. Now, what is sepsis? There have been several definitions along the time, but according to the latest update, sepsis is defined as a life-threatening organ dysfunction due to a dysregulated host response to infection. On the other hand, septic shock is defined as a subset of sepsis in which particularly profound circulatory, cellular, and metabolic abnormalities substantially increase mortality. Both sepsis and septic shock are major healthcare problems, impacting millions of people around the world each year and killing between 1 in 3 and 1 in 6 of those affected. Sepsis is important to understand that it's considered as a medical emergency, and therefore the early identification and appropriate management in initial hours after the development of sepsis improves patients' outcomes. Next, please. Now we're going to talk a little bit about the sepsis screening tools, which are designed to promote early identification of sepsis and consist in manual methods or automated within the electronic medical records. There is a wide variation in diagnostic accuracy of these tools, with most having poor predictive values, although the use of some have been associated with improvement in care processes. The screening tools may be used in patients who are in various locations. That's something important to know, such as in patient wards, emergency departments, and intensive care units. Currently, the existing tools are the SIRS criteria, which stands for Systemic Inflammatory Syndrome Response Syndrome. Also, we have the patient's vital signs and signs of infection. We have the QSOFA, which stands for Quick Sequential Organ Failure Score. We also have the SOFA, which is the Sequential Organ Failure Assessment Criteria. And then we have the NEWS and the MUSE, which are both the national or modified early warning score. Next, please. When we talk about QSOFA, we have to know that it uses 3 variables to predict the death or prolonged ICU stay in patients with known or suspected sepsis. For instance, when 2 of the following variables are present simultaneously, the patient is classified as QSOFA positive, meaning that there is a greater risk of death or prolonged ICU stay. These variables are a Glasgow coma score below 15, a respiratory rate over 22 breaths per minute, or a systolic blood pressure below 100 millimeters of mercury. Next. However, numerous studies have investigated the potential use of QSOFA as a screening tool for sepsis. The problem is that the results have been contradictory of its usefulness, and even have shown that QSOFA is a poor predictor of short-term mortality in all patients. Even current data suggests that QSOFA is more specific, but sometimes less sensitive than having 2 of 4 SIRS criteria for early identification of infection-induced organ dysfunction. Therefore, we might say neither SIRS or QSOFA are ideal screening tools for sepsis. All healthcare professionals, including pharmacists, need to understand the limitations of each tool. Next, please. Now we're going to talk a little bit about the treatment goals in sepsis. And within the sepsis treatment goals, I can say that there are 3 major elements. The early and effective antimicrobial treatment, which includes the source control and the antibiotics. And this one will be focusing later. Where there's another one, which is the resuscitation, which is related to fluid replacement and vasopressors. And of course, the supportive therapy, which includes several therapies, such as the corticosteroids. Next, please. Now we have the early and effective antimicrobial treatment, and there are 2 key strategies within this one. The source control, which is more related to prevention, and this might include the drainage of an abscess, debriding infected necrotic tissue, removal of a potentially infected device, or even a definitive control of a source of an ongoing microbial contamination. When we talk about the antibiotics, it's important to consider that the signs and symptoms of sepsis are non-specific and often are like other diseases. For instance, a third or more patients initially diagnosed with sepsis turn out to have non-infectious conditions, and therefore it's recommended that appropriate routine microbiological cultures, including blood, should be obtained before starting antimicrobial therapy in patients with suspected sepsis and septic shock. Many times it will take some time to get these cultures or sensibility results, and therefore empirical treatment should be started as soon as possible. Next, please. Also, I would like to comment that there are some periods for the antibiotic treatment in sepsis, and of course, I believe hospital pharmacists should be actively involved in all these elements. The first one is time to antibiotics. Here, the pharmacist can make sure that antibiotics are being administered in the right time. Early administration of inappropriate antibiotics is one of the most effective interventions to reduce mortality in patients with sepsis. Although sepsis must be managed as an emergency, we must consider that starting antibiotics should be balanced against the potential harms associated with administration of unnecessary antibiotics to patients without any infection. Another one is the antimicrobial choice. Here, pharmacists can be very helpful to help clinicians in selecting the right antibiotic for every patient. There are several recommendations that should be analyzed by the pharmacist to make any suggestions, and we have two examples. For instance, in adults with sepsis at high risk of methicillin-resistant staph aureus, such as MRSA, it is recommended using empiric antimicrobials with MRSA coverage. Another example is when we have patients at high risk of multi-drug resistant organisms. It is suggested that the use of these two antibiotics with gram-negative coverage instead of using only one gram-negative agent. Another point is delivery of antibiotics. For instance, in beta-lactam, antibiotics may be subject to changes in pharmacokinetic parameters in sepsis patients, resulting in subtherapeutic concentrations. Contrary to conventional and intermittent infusion, that those are infusions in less than 30 minutes, the administration of prolonged IBU infusions results in sustained beta-lactam concentrations, which is more appropriate considering the pharmacodynamics of these drugs. Hospital pharmacists, therefore, should be aware of this information and make the right recommendations for antibiotic infusion times. Another subject is the pharmacokinetics and pharmacodynamics. For sepsis patients, it's recommended that the dose optimization of antimicrobials is based on pharmacokinetic and pharmacodynamic principles and specific drug properties. This is because might be some scenarios that affect the concentration of antimicrobials. For instance, augmented renal clearance, hypoalbuminemia, acute kidney injury, and extracorporeal membrane oxygenation. And pharmacists should intervene when necessary, especially if a dose needs to be adjusted. Something else that is really important is the de-escalation of antibiotics. It is widely known that antimicrobial exposure is linked to the development of antimicrobial resistance. And there should be a plan to reduce both the number of antibiotics administered to the patient and their spectrum once both the pathogens and susceptibilities are known. And pharmacists can play a key role here, since they should be able to suggest when to de-escalate the antibiotics and which antibiotics should be prescribed during the process. And finally, we have the duration of antibiotics. Here, pharmacists can provide support by selecting an antimicrobial therapy with the shortest course associated with better outcomes as part of the antimicrobial stewardship approach. The optimal duration of antimicrobial therapy for a given patient with sepsis depends on many factors, including host, bacteria, drug, the anatomical site, and this practice has shown to be less costly and with fewer undesirable effects and of course without impacting adversely the outcomes. Next, please. This is an example of the Society of Critical Care Medicine recommendations regarding the antibiotic timing in sepsis, and I believe this is a really key point during the management. Again, time is a key element in the management of sepsis, and pharmacists can actually participate in ensuring that antibiotics are administered in a timely manner. For example, when sepsis is definitive or improbable without shock, the antimicrobials should be administered immediately, ideally within 1 hour of recognition. On the other hand, when sepsis is possible without shock, a rapid assessment should be performed by clinicians, and then the antimicrobials could be administered within 3 hours if there is still concern of infection. And I think these recommendations should be followed in every case. Next, please. Here are some more examples of the empiric antibiotic regimens depending on the source of infection. For instance, in case the source is known and there is a need to cover gram-negative bacteria, pharmacists should suggest the use of piperacillin, tazobactam, or cefepime, or carbapenem, for example, as an example. The antibiotic selection depends on the suspected site of infection, local susceptibility patterns, and patient-specific factors. Also, the suspected site of infection suggests the common potential pathogens and thus indicates the antibiotics that should be an adequate concentration at the site or should have an adequate concentration at the site. It is recommended that pharmacists and other clinicians should be able also to access key information such as the local susceptibility patterns guided by the institutional antibiograms. Next, please. Here, I wanted to comment a little bit more about the broad spectrum of antibiotics used in septic patients. And you know, the need for immediate broad spectrum empiric antimicrobial therapy for some patients with severe sepsis may be sometimes life-saving, but it also put pressure in antibiotics overuse and drive antibiotics resistance as well. Thus, this approach comes with the obligation to try to control the resistance by de-escalating therapy once clinical data becomes available. And pharmacists with appropriate training can suggest an antimicrobial de-escalation strategy. And it can be done in the form of shorter duration of therapy, less broad spectrum agents, fewer drugs, and a combination of these interventions. Next, please. Next, here, that. Currently, we can find some evidence of the impact that pharmacists had within multidisciplinary teams that provide care to sepsis patients. There is an interesting review published at the Journal of the American Society of Healthcare System Pharmacists by Kavanaugh et al., and I also recommend you check it out. This review analyzes the pharmacist's involvement in the treatment of sepsis. One study by Berley et al. Showed that pharmacists' contributions decreased time to antibiotics delivery and time to antibiotic administration as well. Also, an analysis by Flynn et al. Showed that pharmacist involvement could increase the use of appropriate antibiotics within the first hour. Also, this review evidenced that pharmacists were often consulted for dosing and antibiotic selection recommendations in sepsis patients. And the results were very positive for all these patients, since mortality decreased. Next, please. Here is some more data about the same review. As you can see, the results of the study of McLaurin et al. Evidence that the lack of a pharmacist within the ICU team increased in mortality, the mortality rate in sepsis, besides a significant increase in billing, drug charges, and laboratory charges. And finally, the study by Sarani et al. Showed again that the positive results are very important when a pharmacist is involved in reducing antibiotic administration time. Next, please. So here are the key takeaways I wanted to share with you because they are very key issues within the pharmacist role within sepsis management. For instance, the Sepsis 3 introduced new definitions and recommendations, and I believe that every institution or healthcare facility should update their guidelines regarding sepsis management. And of course, there is vast evidence that pharmacists have an active role in the treatment goals recommendation, early and an effective antibiotic treatment, resuscitation, and supporting therapy. Also, I think that pharmacist services have a high impact on the survival rate due to the antibiotic therapeutical optimization and timing in sepsis in patients with sepsis. Next, please. So thank you for your attention.
Thank you so much, Dr. Zavaleta, for that informative presentation. We will go to our next speaker. Our next speaker is Dr. Wendy Lin. She is the Director of Pharmacy at the National Taiwan University Cancer Center. She's an associate professor at the University School of Pharmacy and also the director of the Department of Pharmacy at the NTU Cancer Center, like I mentioned. She and her colleagues established a therapeutic drug monitoring of antibiotics at the NTU hospital system and have published several peer-reviewed articles on that as well. Dr. Lin, you can go ahead.
Yeah, thank you. Hi, everyone. It's my pleasure to be here and presenting the topic of hospital pharmacists using clinical decision support system for antimicrobial stewardship program. Next, please. Yes. Within my talk, I will present the roles of pharmacists in the stewardship programs in the hospital based on the literature review. I will also mention about the use of clinical decision support system to implement the ASP. Next, please. So I'm from the National Taiwan University Cancer Center, and it's my honor to be here and network with our pharmacists all over the world from Taiwan. Next. The first objectives of my presentation is Antimicrobial Stewardship Program, so-called ASP. It was called Antimicrobial Management Program or Antibiotic Control or Restrictions. I'm sure physicians, they don't like to be controlled or restricted, so they always call us the antibiotic police. After the name of the control or restrictions switched to the stewardship program, it has been adopted well in the medical field. The purpose of the stewardship program is to promote the better use of antimicrobial agents. We want to improve the patient outcomes and not increase the multi-drug resistant organisms. So in summary, the program is in order to reduce the healthcare costs without causing any adverse effects or decrease the quality of care. Next. Next, please. Oh, thank you. The team is a multidisciplinary. Yes, this is the right slide. The stewardship program has a lot of discipline involved in the program. The pharmacists play an important role, including the patient care as a clinical pharmacist, or we even participated in the pharmacy and the therapeutic committee, so-called P&T committee, or serve as a co-director for the stewardship program. Next. From here, you can see the importance of the stewardship program because it is part of the development goals of FIP to transform global pharmacy. So next, in detail, we can see there are 3 domains of the goal, including the pharmaceutical workforce and education, the clinical practice, and the research and the development. All of these are in order to establish the antimicrobial stewardship program around the world. Next. When we look at the United States, their CDC also announced the core elements of hospital stewardship programs. So among the 7 core elements, there are 2 related to pharmacists specifically, including pharmacy expertise. So as we said earlier, pharmacists can be co-leader of the stewardship program or the clinicians. And the actions, including the pharmacy-based interventions, there are 3 aspects of the interventions. All can be initiated by pharmacists using the electronic health records. Next. The first interventions are pharmacy. It's kind of slow. Maybe it's Friday night in my area. Okay, the first one is pharmacy-driven interventions. So there are several interventions we have done every day during our practice, including to verify the indication of the newly prescribed antibiotics. And we try to switch from IV to PO if the patient can take orally and the infections are improving. And we try to do the dose adjustments, optimizations. And for some situation, the patient don't need antibiotic combination, and we try to discontinue the duplicated antibiotics, or we do the automatic stop orders. Next, please. The second intervention is called the broad interventions. During the process of the culture, we usually start empirical therapy right after the culture specimen obtained, and then we switch to definitive therapy, such as the antibiotics with narrow spectrum or more specific to the bacteria, the organisms. During the process, we can do the front-end approach or the back-end approach. The front end, more like the pre-authorization by the ID pharmacists or ID physicians. And the back end is the prospective review or the reviewed or the reviewed after the end of the prescriptions and give the feedback to the physicians. Sometimes we give the prescriber 48 hours for the empirical therapy before the culture obtained, before the organism identified. And so we need the time out to reevaluate if the antibiotics is needed. Okay, next, please. And the third intervention is more specific to certain infections or syndromes. There are several infections commonly see for the patient admitted in a hospital. There are lower respiratory tract infections such as community-acquired pneumonia, urinary tract infections, skin and soft tissue infections. more than half of the antibiotics are prescribed for these infections. So we need to make sure the antibiotics are not overused or misused for those infections. Therefore, the interventions are needed. And for MRSA or Clostridium difficile infections, we need more controls or management of the antibiotics. And for the culture-proven invasive infections, we need to choose the best optimized antibiotics for those infections. Next. And in Europe, the European Commission also noticed the guidelines to the prudent use of antibiotics. They specifically mention about pharmacists. We should dispense antimicrobials with prescriptions, not just sell to anyone who wants antibiotics. And we need to make sure the patient and their caregivers know how to use the antibiotics so they can have a good adherence and to ensure the treatment success. And they also need to know if they have any leftover antibiotics, how do they dispose? They're not supposed to just throw away anywhere, and that may cause the environment pollution. And they need to watch out any adverse reactions, drug-drug interactions, and to make the public aware of the antibiotics, the importance of the prudent use. We pharmacists need to participate in those campaigns more often than we have now. Next, please. And back to Taiwan, we also have some programs. But before that, let's see there is a systemic review and they evaluate the hospital stewardship program. They found if we do the stewardship programs well, we can improve the patient outcomes, such as to decrease the length of stay and decrease the infection-related readmissions. We also be able to reduce the use of antimicrobials and lower the cost of like hospital medical courses and the patient costs. And combine those three aspects, we find the value is high if we do the antimicrobial stewardship in the hospital, because we can create the beneficial clinical and economic impacts. Next. With that in mind, there was a campaign, national campaign in Taiwan, supported by the CDC Taiwan a few years ago. We targeted the healthcare associated infections and we tried to lower the antimicrobial resistance. And there are several accomplishments, including the establishment of the surveillance of antimicrobial resistant detecting system. And in the hospital accreditations and infection control inspections, they consider the ASP is required for the hospital. And the CDC also set up some e-learning and a few national campaigns for the antibiotic awareness. With the mind of the One Health strategies, they also held the international conference in order to benchmark the stewardship program and resistant status. Next. Okay. In those strategies, there are roles for pharmacists, such as monitor the antibiotic consumptions and assess the appropriateness of the prescriptions. And we can involve in all parts of the antibiotic courses, including the drug, dosage, duration, and the escalations. Those are very important when we treat the patients. The 5D, the diagnosis is more like the work physicians usually do. Okay, next. But as you know, there are so many antibiotics and several newer antibiotics. So we have to remember all the details of the drugs. It's very important. It's very difficult. In this era, the clinical decision support system has been created and used in the our healthcare system. Since 2008, there are several CDSs has been created and conducted in our system. But the antibiotic control and the management of controlled substances have been always part of our practice. Next. For example, in our hospital, there are 4 lines of 4 levels, types of antibiotics. The second line, the medical resident needs to fill out the questionnaire in order to prescribe those antibiotics. Like they have to evaluate in the form, like why the patient needs the antibiotics and their symptoms and signs and their risk factors for complications. If the antibiotics are broader spectrums, and then the use of the antibiotics need to be approved by the attending physicians of the team. For antibiotics indicated for the resistant pathogens, they are restricted to the infectious diseases physicians. Next. So the list is very long. And you can see some newer antibiotics available in Taiwan, but not all. Next. Since we mentioned about the clinical decision support system earlier, the definition is to use the computer applications to provide the guidance to practitioners in order to do a better diagnosis and treatment. The target of the CDSS, including the antibiotic prescribing, the alerts, we use the CDSS in order to optimize the antibiotics to support the de-escalation, like the presentation earlier, and we always do the de-escalation when we know the organism and the susceptibilities. And we also use the surveillance to track the resistant patterns and antibiotic use. We provide the feedbacks to the prescribers for education purposes. Next. There are so many platforms to deliver the CDSS. Some hospitals use the CDSS integrated into their electronic medical records, and some are web-based platform, and some can be used in their PDA or the pad or their smartphone. And there are some standalone softwares as well. When we do the CDSS, usually the upper administrators in the hospital, they want to see the outcome to make their money worth. So worth of it. So we usually show the decreased antibiotic consumptions or the adherence to the updated guidelines or medical recommendations. We try to show a better dosing regimen, the lower mortality rates, the lower C. diff rates, and the lower cost to show the effectiveness of the CDSS for stewardship program. Next, please. Then I will give 3 examples, like how people around the world do the CDSS to support the stewardship programs. The first one is from Belgium. They use computer software to check the medication appropriateness, especially for antibiotics. So this is a pharmacist-led medication review service, and the clinical pharmacist review the medications and discuss his or her recommendations with the physicians. And with the help of the software, the pharmacist can easily identify the potentially inappropriate prescriptions called PIPs. You can see the on the right upper, the figures before the implementations of the CDSS, the proportional residual PIP were 75% in average and decreased to 8% after the implementations of the CDSS. And we also see the incidence rate of the PIP decreased from 3% to 13%. I'm sorry about the slides. The arrow didn't show up. So the conclusion of this study, they found use the software, they could optimize the clinical outcomes and minimize intended consequences of antimicrobial use. Next, the second example were from UK, and they also have software, and it's a commercialized software which can collect real-time information, including microbiology, biochemistry, lab data, hematologic results such as white count and hemoglobin, and the medications and the patient's demographics informations. The software also allow users to code alerts and reports on specific patients' information, and they can have the work list, and they can choose they want to review all the medications and progress notes or just ongoing monitoring. So they see it's for the same ID pharmacist, the pharmacist review all the triggered alerts and the specific reports. So with the assistance of this CDSS, the productivities in terms of the case reviews increased from 138 to 264, and the pharmacist was able to provide more interventions from 169 to 298. And the type of interventions we will see in the next slide. And the other significance of these results, this study results, is they were able to decrease the defined daily dose from 283 to 231, in which the p-value was less than 0.05. So in the next slide, you will see the results. They compared the pre-implementation and the post-implementations. You can find the highest or the most interventions were stop antibiotics, but there were no significant differences before and after the interventions. The biggest differences were the dose drug optimizations, which increased over the year, and especially after the use of the ICNet, which is the commercialized CDSS. They also found pharmacists escalate antibiotics, not de-escalate. It's it was escalation of antibiotics for patients in in the worsening situation. Next slide. And the third case is the management of Staph aureus bacteremia in adult patients in the United States. It's interesting because it's in the hospital in Atlantic City. And we have students having clinical rotations over there for many years, and the place called a Grady Hospital. We found they made an intervention. It's a comprehensive management bundles. They use the alert to detect the Staph aureus bacteremia, and the alert would trigger the prescriber to have the order set in the electronic health records. They also have a bundle care with 6 components, including ID consultation, the source control of the bacteremia. They also require the medical team to repeat blood cultures, do the EKG, because the endocarditis is the most worst complication of the Staph aureus bacteremia. In the bundle, they also do appropriate antimicrobial management and try to make sure the duration of therapy is optimal. And the results, they found if with the CDSS support, the completion of the bundle elements increased almost double. So it's very significant improvement of the treatment outcome and also the practice. Next, please. So in summary, we found in the literature and also the guidelines or suggestions from our society, pharmacists demonstrated an essential role in the stewardship programs in hospitals globally. And we are the drug experts, and we can make suggestions in terms of the antibiotic type, dosage form, the duration of treatment, and we should do de-escalation or escalation if necessary. Since stewardship program is one of the important development goals of FIP to transform global pharmacy, we need to use our knowledge and skills, and also with the assistance of the clinical decision support system, we try to implement the stewardship programs to improve patient outcomes and lower the intended consequences of antimicrobial use. With that, thank you for your attention.
Thank you so much, Dr. Lin. I really appreciated seeing the guidance from the government and how involved everyone is, and also the restrictions as well. With that, we will go to our third speaker. And we've got Dr. Sid Pantawala. He's a professor and chair of clinical pharmacy at the University of Sydney, Royal Prince Alfred Hospital in Australia. He's the chair of clinical pharmacy and is jointly based at both at the University School of Pharmacy and also at the hospital site. He is a clinician researcher in the intensive care unit and has published over 150 journal articles, including journal articles in New England Journal of Medicine, JAMA, Intensive Care Medicine, and Crit Care Med. Welcome, Dr. Pantawala. The floor is yours.
Yeah, thank you. Thank you for inviting me. Next slide. All right. So I'll follow on from those two great presentations. This is just a picture of the University of Sydney. Next slide. Okay, and my focus today is really on software and technology that could support antimicrobial stewardship. And my focus obviously is on the critically ill, because that's what I do. And I wanted to share with you some of the things we do in Sydney, and maybe you could take that back to your institutions. Next slide. This is the beautiful Sydney Harbor and Opera House, and I'm lucky to be here. And that red arrow there, that's where the Royal Prince Alfred Hospital is located, right? So it's an urban hospital. Next slide. This is the Royal Prince Alfred Hospital is an old hospital, was over 100 years old, opened in 1882, and it obviously doesn't look like this today. Next slide. And that's what it is like today. It's a 1,000-bed hospital. It has some parts that are very new, some parts that remain old and historic. It's the RPA has had a lot of firsts. It's the largest hospital in the Sydney Local Health District. It had the first liver transplant, the first open heart surgery, a lot of things, and certainly is known as one of the best hospitals in the world. Next slide. So when it comes to technology, I can break it down to, there are two things. One, you need good information, especially for antimicrobial stewardship. And once you have that information, is you make good decisions. If you don't have the information you need, you just can't make those decisions. So that's why technology is so important, and how you leverage that to make things really efficient and valuable for frontline clinicians. Next slide. This is an example of how we are able to, how things are, at our fingertips. So for example, we have on our intranet in our hospital, you can simply search for, I took a screenshot of vancomycin there, and it pulls it up, and all the different formulations and the restrictions on each antimicrobial will show up. So when you're trying to roll things out broadly in an institution, you really need everybody using the same systems where they are very comfortable knowing what are the restrictions, what are the indications for them. In New South Wales, we have the Clinical Excellence Commission has come up with this traffic light system. So we have antimicrobials that are green, orange, and red. And all hospitals use the same system. And although individual local hospitals can change what antimicrobials have each color, but a green antibiotic would be something that there are no restrictions. They can be used as long as it's reasonable, for a reasonable amount of time and the right indication. And orange has some restrictions. If it's used beyond certain indications or beyond certain periods of time, then it requires approval from infectious disease. Okay, so it's sort of a middle ground. A red antimicrobial, if that's being used, will require infectious disease approval. Now, when that approval is acquired, infectious disease, we have a very standardized system. They provide a number, so it has an issue number. It has it's in the specific format. It has an authorized approver and the date the approval expires. And now, why is this useful? Because this goes in the electronic medical record in the order itself. So anyone else looking at it knows exactly when that this is approved, when this is going to expire, and when they can follow up with that. It also goes in the clinical notes. And so everything is tracked so that we know when to de-escalate, when things are, when the infectious disease service, AMS, needs to keep an eye on things. Next slide. It's also what I found is, there's data that is you need good data real time to make decisions, and then you need data to look for surveillance of what is really going on in the hospital. So we're lucky enough that we have the Philips system in the ICU, and the Philips system has been in our ICU for more than 10 years now. Everything is completely electronic, and it's got a nice query tool. So I just took a screenshot of the tool, and you can run just about any variable you want, any drug you want, and then it gives you sort of an Excel file that you can download. And then the key is how you're going to put together that information to make sense of all of it. The other option is, all of this is really stored within an SQL database. So we have a database administrator that every single thing in the ICU is stored within this database. And now it's got, data from 10 years, a decade of data. And, you can query this database, obviously, with software like ours. So if you didn't want to use a query tool, which might be a little bit cumbersome, you can directly query it using statistical software. And, through R, you can then manipulate that data to give you any answer you want just by writing the right code. Now, we're at that stage where we're doing that, but we still have they're very cautious about approving who has access to the SQL, the actual database, because it basically opens up the floodgates for just about anything. But it's been really valuable for just surveillance and just research in general. Next slide. This is Emma. Emma is our antimicrobial stewardship pharmacist. So I wanted to put her up there because she's the one who does the day-to-day work. Okay, I'm around there, but she's the one doing the work. And you can see she has her screen is, she has R loaded up there with some code that's written, and that's how just is able to run these reports. Next slide. Okay, so Emma is great at you can play the video. So this is sort of an Excel file that's not so clean, and then she runs a macro, and boom, right there, it's a cleaned Excel file for data that she wants. And I don't know how she's very skilled at creating these macros and making sense of all of this information. So you really have to use those tools, and pharmacy has come a long way, and you really need both clinical knowledge, but for efficiency and to make good decisions, you really have to now, the antimicrobial stewardship pharmacist has to have good information technology skills, maybe some programming skills. It's really changing how things are going. Next slide. So the one thing I wanted to tell you, I guess the next frontier here is, I think you're familiar with this. IDSA practice guidelines, have changed now to have recommending AUC over MIC for vancomycin therapeutic drug monitoring with a goal of 400 to 600. And, that's in the recommendations now. A lot of, how do you do that? You either take, 2 levels and instead of troughs, and you have to measure area, calculate area under the curve, which can be a little bit of a cumbersome process, or you can use Bayesian software. Okay, so since I'm talking about software and technology, I thought this was a valuable thing to think about. Is this seems to be the next frontier now, and many hospitals down in Sydney have started using Bayesian software, but we were a little cautious about it. Next slide. So, what about the cost? These things are quite expensive. Can you justify them? There are quite a few programs out there. Now, the good news is right now, if you look at TDMX, it is free. It's a free program. And, I just put in some numbers in TDMX to show you what it looks like if you haven't used it. But it is available. Anyone can go on there and put in data and see what the AUC would be based on your patient's either a priori or posteriori values. Next slide. So there are a lot of different software products out there, and which one do you use? And it's difficult, and one of the things about this is that sometimes the softwares use different models within them, so we weren't quite sure what is the best model. Are those models really have good specificity? Are do they have good precision in terms of the actual values? So we were a little unsure about this. Next slide. Yeah. Are there any others? I'm not sure if I missed any, but this is what we ended up doing, and we harnessed actually our electronic medical records and had one of the largest data sets of close to I think it was close to 500 values, concentrations of vancomycin. And what we recently published it in Critical Care Medicine, but what we really showed is that the models didn't have very good precision. They weren't what we thought they were going to be. So it really cautioned us about using these in the critically ill. After we did this in our population at the Royal Prince Alfred Hospital, and so this was the largest data set out there. And so I think we're at the stage where when we think about using technology, where we've kind of taken a step back until the models become a little better. We probably would be hesitant using it in the critically ill. But we are still thinking, well, we need to do 2 levels now, and use the log-lin method and do it that way. Next slide. Okay, so final thoughts. I think this was attributed to Albert Einstein, which is I've talked a lot about technology, but just remember that at the end of the day, even though I would say our PA is quite advanced in a lot of ways, our antimicrobial stewardship pharmacist still has a lot of interaction with the teams, to have that, with the nurses, to know what's going on, and so that we can make those right decisions that sometimes you don't get from the data. Next slide. And I'll leave you with that. Thank you very much.
Thank you very much, Dr. Pantawala, and all our other speakers. We will now go into our panel discussion. There have been some questions submitted through the box, and I see Dr. Zavaleta has been answering some, but for the sake of the recording, I will definitely read those out loud and direct them to everyone else who would like to answer as well. The first question that I have is asking about erythromycin being a prokinetic agent of choice when others are contraindicated. Is it wise to use erythromycin off-label for prokinetic mechanisms associated with the resistance issues? Dr. Zavaleta, did you want to read your answer out loud?
Yes, I'm sorry. I was answering another question. I believe optional strategies in other countries of healthcare settings should be more related to local susceptibility and availability of antibiotics. Therefore, we have to be careful because off-label use of certain medications can be risky, depending, of course, of the country. But there are other options. If there are other options available to you, if the resistant patterns are a concern for you, you might suggest those options to your local pharmacotherapy committee or infectious disease committee. And then you can provide a guideline or recommendation for physicians and pharmacists in that case.
Definitely. Thank you so much. Wendy or Sid, did you have anything else to add?
Nothing to add there. I guess it's not really a technology issue, but certainly I don't see erythromycin being used a lot in our setting.
No. Okay, great. I did actually have a question for Dr. Pantawala. You talked a lot about the technology and software utilization to kind of drive, particularly in this setting, antimicrobial use. And you talked about your AMR pharmacists being able to monitor some of that data. How have you been able to train other pharmacists and other specialties, as well as leadership, to kind of analyze and interpret that data that you provide them?
Right. So I guess one of the things is that we have a very standardized format in the way that the reports are. It depends. Sometimes we have standard reports on utilization by department and how they're using it, so that that feedback can be provided, so they know how to read those reports. Uh, Sometimes the problem is dissemination of those things, and do they actually read it? I don't know, but we can definitely create them. I'll tell you that. Uh, so it does open up. We have to reach out to them beyond that, especially if there's a problem in terms of the actual data and the analysis. That's going to be done within the AMS service, and within, I'll help out with, especially when it comes to statistics and that kind of thing. So there, I would say that the external folks, they're more consumers of what we do, and we just give it to them.
Thank you so much. This question I can direct at Dr. Lin. How effective is the antimicrobial stewardship in the community setting? And would you follow the same team like the one used in the hospital? And I see Dr. Zavaleta has answered as well. Dr. Lin, if you can answer, and then Zavaleta can follow up with his answer as well.
Actually, because I work in the hospital, so I really don't have a lot of experiences or reading about the community based stewardship program. However, as I know, some patients may discharge home with oral antibiotics or intravenous antibiotics. And there are some home infusion team might visit the patients and monitor the lab data or do the therapeutic drug monitoring for vancomycin or aminoglycosides. I think that's also part of the stewardship programs, because we also take care of the dosing, duration, and potentially de-escalation or monitoring of side effect. However, I really don't know if there are a lot of studies on those effectiveness or the cost associated with the community-based stewardship program. Thanks.
Sure. Thank you. Dr. Zavaleta, did you want to read your answer?
About the community pharmacy. All right. Let me see what I wrote here. I've seen actually in several congresses that there are several initiatives around the world in the implementation of antimicrobial stewardship programs in ambulatory care and community pharmacists. And I answered that it's important the pharmacist is part of it. But I think that's a collaborative process between the prescribing physician and the community pharmacist, though, so the pharmacist can, with clinical information available, provide certain recommendations regarding the treatment for that specific patient. And of course, that depends on, local susceptibility patterns and resistant patterns as well. But yeah, that's something that's been implemented in several countries and cities.
Yeah, I would echo that. In the US, actually, there's been more of a push to have outpatient and ambulatory antimicrobial stewardship as the next step. A lot of hospitals who get accredited are being required to participate in some kind of program. So definitely looking forward to having some more experience with the rest of the world as well. I have a question for Sid. What has been the impact of this technology in controlling or optimizing antibiotic resistance at your hospital?
Well, I can tell you, so I know about the resistance patterns and we know what technology we have. The tricky part is figuring out what kind of relationship, if there is any, because there are so many different things beyond technology that we would do to limit, to optimize the use of antimicrobials. So what I'll say is that, for example, our MRSA is not nearly that high as what's in the United States, where it's 50% MRSA. So we are quite low, in fact. So we don't really need to start empiric vancomycin on people a lot of the times. So in many ways, I feel that we're doing a good job so far in curtailing some of those resistance patterns, at least but it's also a local thing. So sometimes it might be different in other areas of the country as well.
Yes, definitely. And I think something that you and maybe Wendy can answer as well is there's a question about if the technology has made the pharmacist any smarter, it has the opposite effect. And I know that's that's a question that comes up with clinical decision support system and any other technology that we're using. So what are your thoughts on that?
Well, I think that we're still smart so far. Our antimicrobial stewardship pharmacist, she has great skills in making sense out of data. I use a lot of statistical software and do data manipulation, but I would think that I still know how to dose antimicrobials and those types of things.
Wendy, did you want to weigh in?
Yes. Let me see. Okay. Oh, sorry. Yeah, I also agree with Sid about we are still smart. Even we have the CDSS or the IT support. There are evidence. We didn't publish in the literature, but when we implemented a lot of rules for the CDSS, one was the renal dosing rule, and kind of like we detect the inappropriate dosing if the patient has renal or hepatic dysfunctions. And the pharmacists used to worry about if the CDSS or the IT support would reduce their interventions or make them work harder or more difficult. But actually, after we implement the renal dosing or hepatic dosing rules in the computer, our pharmacists were able to provide even more advanced interventions, such as de-escalation or escalating of the antibiotics, or do the proactive suggestions. So I think the CDSS may save the time and labor to deal with the basic problems of the prescribing. And our pharmacists have more time to do the education or advance their knowledge and the skills, and then they can spend more time with working with the physicians at the bedside rather than checking the details of the dosing and those little things.
Yes, I completely agree.
I just wanted to add is that one thing I just wanted to add there is, I guess the thing is, are we using it as a crutch, and then ultimately we don't know how to walk? And I think from that perspective, my fear is that we lose resources where we get more efficient, and then they say, oh, you don't need that many people, and that's where things will actually backfire on us.
I completely agree with that. Dr. Zavaleta, did you have any feedback on clinical decision support at your institution?
I'm sorry, I couldn't hear you.
Did you have any feedback on clinical decision support at your institution about it helping pharmacists versus not helping pharmacists?
Yeah, indeed. I've been hearing several questions regarding that, and I think that pharmacists or clinical pharmacists should be more involved in several activities within the hospital setting, and training is really important, and the support by the medical director and things like that, they're going to make the difference. Also, I would like to comment something else is that several people is asking about the doses of certain medications, or what to do when we have to adjust any dose. And I wanted to add that there are many tools that are available online. So most of them you have to pay for, but some are free. If you want to check them out, it would be important if we can answer those options in a written form, in order to get that information to other participants. Because someone is asking us what dosage of gentamicin are what we use. And of course, like I said, it depends on the patient, it depends on the site of the infection, it depends on many factors. So there would be nice if we share some of the uh, information resources we use in order to take those decisions.
Yes, definitely. And then this is actually a question that I wanted to ask all three of you. There was a question about what are the prerequisite core competencies to become an AMS pharmacist at your institution and potential geographical setting as well?
Yeah, I try to answer that, and I believe that we have to be very communicative. It's very important that the pharmacist has very good communication skills with other healthcare professionals, nurses and physicians. And of course, there has to be a very important kind of training, whether locally or internationally, training about infectious disease and how to approach the infectious disease patients. I believe that through that training and the knowledge you can get through all the information that is available, like the guidelines we review, you can you can be very helpful to physicians, to infectious disease physicians, in taking decisions for patients.
Well, if you're looking for, there's no certification in Australia that says you are now an antimicrobial stewardship pharmacist. There's nothing like that. Residency programs are starting out, but they're, the specialty residency programs are still far and few between. So they're not something that would be the standard for an AMS pharmacist to have infectious disease, experience. I think a lot of times what happens out here is that we do have, it's a higher level position. So most of them, they go from grade 1, grade 2, grade 3. And usually when they go to a grade 2, which is a higher level pharmacist, they've had that experience in the hospital. So a lot of it is learned on the job. And so I would say our antimicrobial stewardship pharmacist doesn't necessarily have a, the typical PGY2 you would have in a US ID kind of a thing, but she has a lot of experience and knows how to do a lot of things. So that's how it we have others under her training. So so it's sort of the cycle goes on.
Wendy, did you want to chime in with prereqs for your institution?
Yeah, I think it's a very important but difficult questions for me. Like in Australia, there's no residency program or education program specific to antimicrobial stewardship program or certificate. So like Sid said, it's more like on-job training, and almost all pharmacists, when taking care of patients, we deal with antibiotics. So for our, we have when we teach the junior pharmacist, they document all the interventions they made in the computerized the program. And then our senior pharmacists or the specialized pharmacists, they verify the interventions and provide feedbacks to the junior pharmacists as a learning or education parts. But nowadays we want to learn the system of the clinical pharmacists in the United States. So we provide some financial supports to encourage our pharmacists to take the board examination, like the specialized board certified specialized specialists. And we hope we have more people, like a critical mass of the specialists, and then we can establish our own certificates in Taiwan.
Very helpful. Dr. Zavaleta, did you have any more to add?
Yeah, I wanted to share our experience here in Costa Rica, because we don't have a residencies program here, but we got some funding to travel to United States and have a short-term training regarding infectious disease. And when we came back here, we've been able to help other hospitals in my own country in order to establish their own antimicrobial stewardship programs. So probably it's sometimes it's a matter of money, but if you can do and afford and get some funding to, get training in countries that are really advanced in this topic, you can come back to your country and implement several strategies that I think are going to be or make the difference regarding the antibiotic use in locally.
Yes, definitely. I appreciate the fact that Sid mentioned that there's no specialized training. And I think something that we have started in our more community side hospitals as well is the residency trained pharmacists are not there. So there are available certifications. I believe Society of Infectious Diseases Pharmacists as well as MAD-ID do have international members as well. So those are some resources that people could consider as well. And then I'll take one question and then would love some closing remarks from everyone. Talking a little bit about the softwares and programs that are being used to assess, just renal dose impairment and subsequent dosing adjustment of antimicrobials. I realize, again, this is institution specific, but is there specific resources or formulas that your institution follows versus other countries?
I guess I can take that one first. So one of the nice things in Australia is we have something called the ETGs, which is the therapeutic guidelines. And what that is, it's a collection of all guidelines, not just infectious disease, but everything all in one place. And that has information on how to manage every single infectious disease problem, and it's endorsed by the infectious disease groups here. So it's all in one space that everybody uses the same thing. It's got dosing information. Sometimes the dosing information you may want to check more than one source. So in that case, we still have access to things like UpToDate, and all public hospitals have access to UpToDate and Micromedics and all of those things. So we look at all those sources for dosing, but in terms of selection, it's quite well laid out for us in terms of the ETGs.
Great, thank you. Dr. Zavaleta, did you have specific software?
Yeah, we do use the Micromedics UpToDate in order to review the basics of certain medications and daily clinical pharmacy reviews. But also we use the Sanford guide. They have an option for an institutional subscription that you can add your or set up your guidelines, your local guidelines, of course, because it always will depend on the availability of certain medications. It will depend on local susceptibility and resistant patterns. So we're not using it, and it's a certain amount of money. Of course, the budget will depend of each country and healthcare setting, but I will encourage all pharmacists that check that out, but maybe that would be an option as well.
Juan, did you have anything to add for your institution?
Yeah, I think Sid and Esteban provided a lot of several good references, and I also agree with that. But sometimes I found the package insert, like the most updated package insert, are prescribing information are useful as well. But sometimes in my country, we have the Chinese version of the prescribing information versus the original English version. And sometimes they are not consistent occasionally, and I think that's a problem. The other thing is like the extended infusion of beta-lactams. That's the that has been proposed in the literatures, but not necessary in the prescribing information. Or like vancomycin, the AUC target is not in the prescribing information either. So I don't know if it's important for the drug company to update their prescribing information, but I think it's not mandated by the regulatory body. So I don't know. I want to ask your opinion about this one.
Sure. Yeah, it was. It's definitely very enlightening to learn about what is being done. I think I agree with Sid that we have guidelines as well at my institution. We try to make them as available as possible. I know other institutions have developed apps, but again, there comes the whole object of having financial support to develop that app. And then upload your guidelines, your local guidelines. So those have been very helpful. We have it on our intranet site, and that's where we share our antibiograms. I agree with you that the package insert will not have some of the extended infusion beta-lactam dosings. We did just roll that out, and that we've had to just change it in our order set as well. So the EMAR system that we use, we have defaulted that to only be a certain way, so that kind of cuts down on the probability of people not ordering it appropriately. So.
Yeah, same here.
Yeah, great. Thank you so much. I would like to have any last thoughts from you all before we end this session. Anyone can go first. Sid, do you want to go first? Okay.
Yeah, like I said on my key takeaways, it's really important that pharmacists around the world can be more actively involved in the antimicrobial use, whether we're talking about sepsis or other infectious diseases, but we have the knowledge. The only further steps we might take is getting some more training and probably help from a software, but we are the experts in the medications. We're the ones that can be very helpful to physicians or other healthcare professionals to take their decisions. So it's really important if any one of the participants are really or really like the infectious disease and antibiotics, I encourage them to try to implement strategies in their own hospitals, or even community pharmacists, like one of the persons asked about it. So there's a lot of work to do, but I think that we are the ones that have to take the leadership on this issue.
I guess I can go next. What I'll say is that I moved from the United States a few years ago to Australia. So I'm actually from the US. So I've seen two different things. And one of the things I really like about Australia is the standardization. So there's a lot of standardization, and that brings with it a lot of efficiencies. And so think about how you can make your practice more efficient, because really you might be doing a lot of things, chasing your tail, when you can really make things efficient, and that ultimately frees up your time to do other things with antimicrobial stewardship. So think of different ideas from what you've heard today and what you can implement at your institutions.
For me, I think pharmacists are the key person of the antimicrobial stewardship programs, because no one else like us truly focus on the balance between the effectiveness and the safety of the patients. And I think we have a lot of opportunities, not only focusing on the medications, but also we can get more involved in the IT, like software, and how do we improve the CDSs like the way we want. Like I saw a question about the like which equation or the way, how do you calculate the creatinine clearance for renal dysfunctions? And there are a lot of controversials and inconsistencies. And the other part of the stewardship programs, like the antibiogram, we can also help about to select the right medications and do the floor specific or ICU specific or outpatient specific antibiogram, working with the laboratory personnel. So I think we have a lot of potential and untouched area for us to work on and explore the possibilities for our patients.
I couldn't agree more. Thank you so much to all three of our speakers and to all the participants who took the time to join us. There will be future events as well, and we look forward to having you attend those. Thanks again. Have a great day, everyone.
Thank you.
Thank you. Have a good day.